with primary renal tubular acidosis. For that reason, I have made this update of the subject with data from my thesis research conducted in 2009. The evaluation of nutritional status allows us to know the importance of nutrition on growth and development of children. We all know that children are considered as a group of maximum vulnerability, since in the first 2 years of life there is a weight increase of more than 200% and an increase of more than 50% in height, which would be affected if the child has a limiting condition. Among the main factors that can affect the growth of children, we have nutritional factors such as deficiencies or deficits due to decreased intake, socioeconomic factors, low availability of money for parents to buy enough food in quantity and quality, endocrinological factors such as hormonal failures or deficiencies such as growth hormone, or pathophysiological factors such as primary renal tubular acidosis. In this sense, I can say that the term primary renal tubular acidosis refers to a group of disorders, either in the absorption of bicarbonate, the excretion of hydrogen, or both simultaneously at the level of the renal tubules, without affecting the glomerular function or the glomerular filtration rate. This condition is characterized by hyperchloremic metabolic acidosis, which help to make a differential diagnosis from the other metabolic acidosis. RTA is classified into 3 main groups according to the area of the renal tubule that is affected. Distal RTA of type 1, characterized by a failure in the excretion of hydrohenions. Proximal RTA or type 2, characterized by a failure in bicarbonate reabsorption. Hyperkalemic RTA or type 4, characterized by very high potassium levels. Type 3 RTA is a combination of type 1 and type 2. RTA occurs early in life and affects the growth of children, but the intensity and the way in which it affects the nutritional status and growth of the child has not yet been fully described. Chronic metabolic acidosis causes several negative effects on the nutritional status and longitudinal growth of children, and this is mainly because it affects different hormones and systems, such as growth hormone-like factor, decreased appetite, an increase in osteoclastic activity, decreased intestinal calcium absorption, etc. Regarding nutrition, it is known that children with this type of pathology must follow an appropriate feeding plan that allows them to reduce the lack of appetite, weakness, and irritability, some of the classic symptoms of this condition. For this reason, some objectives are maintained to reduce the symptoms and improve the nutritional status. Basically, nutritional treatment should be personalized and focused on the condition of the child diagnosed with RTA, a treatment that promotes weight gain and appetite, favors the correction of metabolic acidosis, controls protein intake, and, above all, benefits the longitudinal growth of the child and helps in the prevention of complications. In this slide, you can see a group of basic recommendations to keep in mind when programming the feeding plan for children with RTA, and knowing that this condition occurs at the very early age. We should recommend and maintain exclusive breastfeeding for the first 6 months of life, and then adjust the type and amount of food to be provided to the child according to their conditions. Clearly, much is known about the pathophysiology, short and long-term consequences of primary RTA, but how much do we know about the intensity of nutritional alterations and their effects on children's health? A question arises. Knowing that children are a group of maximum vulnerability and that several factors can affect their growth and harmonious development, what is the nutritional status of children with a recent diagnosis of primary RTA? We started the design of the research work with a clear and precise general objective: to evaluate the anthropometric nutritional status of children under 12 years of age with primary renal tubular acidosis of recent diagnosis who attended the nutrition service growth and development referred from the nephrology service at the Children's Hospital JM de los Ríos, Caracas. Since primary RTA is the most frequent of the tubular dysfunctions, where the main characteristic is the affectation of the adequate growth, and that is why it is important to know the nutritional status of these children with an approximation of the adequate nutritional treatment. The specific objectives are focused on the determination of the nutritional composition of children through the evaluation of anthropometric parameters such as weight, height, skin fold, and circumferences, and the combination of these parameters. Regarding the methodological design, an exploratory, descriptive, cross-sectional, and prospective study was carried out on children under 12 years of age, referred from the nephrology service for evaluation and treatment. The cutoff points for the nutritional anthropometric diagnosis are the distribution of percentiles, referenced by the cross-sectional study of Caracas, and the combination of the different indicators to make the diagnosis. It allows to perform the current nutritional diagnosis for children under and over 2 years of age. Growth diagnosis with cutoff points according to percentile distribution. Now I'll show you the result of this research. After 1 year of research, the following results were obtained. Figure number 1. The distribution of children according to gender. We found that 55% of the 20 children evaluated were female, a data similar to world reports, where it is found that this pathology is more frequent in girls than in boys. Figure number 2 shows the age of children diagnosed with RTA, finding that most of the diagnoses were made at an early age, 8 cases in children under 1 year of age, and 5 cases in children between 1 and 2 years of age, which represents 65% of all cases. Table number 1 shows the distribution of patients according to the nutritional diagnosis and the different variables measured in the study. The values observed in the first column of the table number 1 indicate that there are statistically significant differences between the average of the normal group with respect to the average of the malnourished group, since all the p-values are less than 0.05, p less 0.05. So there is such a difference between the average compared here by means of the t-test for independent samples. Table number 2 shows for the weight for height indicator, 40% of the children were found to be underweight in relation to their height, while the remaining 60% were found to have a normal weight for height. When height for age is analyzed, 65% for the children were found to have low height, including low normal height, 3 cases, and low height, 10 cases. This situation is much more marked with the weight for the age indicator, when 85% of children have a low weight for age classification. In relation to the circumference of the left arm for age, it can be observed that 13 of 20 cases studied, 65% have low circumference for age, while 7 cases present normal circumference for age. It is good to highlight that none of the children evaluated presented low head circumference for age, which indicates or refers to the fact that the weight of their brain mass has not been affected. As for the triceps fold for age, it can be said that since it is an indicator of body composition, it shows that 13 of the cases have a low adipose mass, or what is the same, a low caloric reserve. On the other hand, it can be said that in relation to the scapular fold, 8 of the studied cases presented a low fold, while 12 cases presented an adequate fold. Like the precipital fold, this is an indicator of body composition that shows a low caloric reserve. The muscular area for age is also an important parameter to highlight, as it indirectly refers to body composition of the cases studied, and when we see that 5 children fall in the low range, it simply indicates that the protein reserves are low. The fat area for age is another indicator for body composition, and as can be seen in this study, 14 cases, 70% present this parameter in the low range. Table number 3 shows the distribution of patients according to anthropometric nutritional and growth diagnosis. 50% of the children evaluated have a diagnosis of low-high growth, 15% have low-normal-high, and only 35% have normal-high, without relating it to the current nutritional status. When the diagnosis of nutritional status is evaluated, it is observed that the incidence of malnutrition is 70% regardless of the diagnosis of growth. But when all the anthropometric diagnoses of nutrition and growth are related, the prevalence are as follows. Low-high with normal nutrition is 20%, low-high with subclinical malnutrition 10%, low-high with malnutrition in critical area 15%, and low-high with mild malnutrition 5%. Low normal high with normal nutrition 5%, low normal high with subclinical malnutrition 5%, and low normal high with malnutrition in critical area 5%. No cases were found with low normal high with mild malnutrition. Normal high with normal nutrition only 5%, and this particular case is the oldest girl in the whole study. Normal high with subclinical malnutrition 5%, normal high with malnutrition in critical area 15%, and normal high with mild malnutrition 10%. Here it can be seen that 95% of all the children studied present some type of alteration of nutritional status either in the short or medium term, such as alteration of nutritional status without growth impairment and growth alterations that are evident in the long term even with a normal current status nutritional homeostasis. Conclusions. 9 out of 10 children present some alteration in growth and or nutritional status, both acute, subclinical and clinical, and chronic forms. As for the intensity of the clinical form, only mild forms were found. The earlier the diagnosis of RTA is made, the less the nutritional and growth status is affected. Early nutritional assessment is important to prevent further malnutrition. This finding leads us to recommend that all patients with alterations in growth and or nutritional status without other apparent pathology should include in their study plan the necessary tests to rule out RTA and thus be able to initiate early intervention. Early nutritional intervention helps to correct inappropriate dietary habits such as excess protein, low vegetable intake, or excess processed food. Promote the consumption of fruits and vegetables in this group of children due to their high alkalinizing power. Thank you very much for the opportunity to make this presentation. A big greeting to all from Caracas, Venezuela. Janet Rodríguez.
Thank you, Dr. Janet, about your presentation. Anyone have questions and inquiries to Dr. Janet? Kindly share question to her.
Thank you. Good afternoon.